Hi, welcome to Exercise Prescription for Stroke Survivors. I'm Doug Alexander. And I don't know how to make the slides go. There's three main learning objectives for today. This is to identify the impairments or the problems and challenges faced by the stroke survivor. And then we're going to describe the ACSM/American Heart Association exercise prescription rec for aerobic resistance flexibility and neuromotor or neuromuscular exercise for stroke survivors. After engaging in this activity, you ought to be able to discuss, interpret, and apply the FIT BP principle of exercise prescription for stroke survivors to a case study that I'll be posting in the discussion area. There's two key references. There's our beloved Get P11, which came out in 2022. And then there's also the position paper from the American Heart Association and the American Stroke Association. This came out in 2014. Billinger is the lead author, but there's a cast of many scientists involved. And it was a comprehensive review of the literature and pulling together expert recommendations for physical exercise recs for people who experience stroke. Now, a stroke is the same thing as a cerebrovascular accident. It's known by the acronym CVA. And during a stroke or cerebrovascular accident, part of your brain experiences an interruption of blood flow. So blood stops flowing to that particular part of the brain. 87% of the time, this is from a thrombosis or embolism. So that's illustrated in the two top images here. So in this image here, we've got a blockage, which is a thrombosis. So that could be from a thickening of the artery that's supplying that part of the brain, or it could be an embolism thrown up from the aorta or the carotid artery at the branch here. Suffice to say, when that part of your, when that artery is blocked, then the neural tissue that's served by the artery dies. There is some collateral circulation, and that's great, but that's the situation. So 87% of the time, it's a thrombosis or embolism. Hemorrhaging is a rupture of an artery or a bleed. That might be like 5 to 10% of the time, and about 3% of the time, it's not known what the mechanism is of the stroke. But in either situation, if you have a blockage or if you have a bleed, then the area that's supplied by that part of the circulation is going to die. There's a lifetime stroke risk between the ages of 55 and 75. For women, it's 1 in 5 women will have a stroke, and 1 in 6 men will have a stroke sometime between the ages of 55 and 75. So depending on what part of the brain is affected and what the functions are that are served by that part of the brain, you'll have different types of phenomenon. The biggest issue usually with a stroke is it affects your ability to send motor commands to your body. So when I say the common neuromuscular effects, every client will have a slightly different presentation according to what part of the brain has been affected. But generally, this is the kind of thing we're going to see. So we're going to have a hemiparesis, which is a weakness to one side of our body, hemi. So another word for hemiparesis is hemiplegia, so weakness to one side of the body. In this image here, we've got a neurologist who's pretending that they had a stroke, and this would be a stroke on the left side of their brain or brainstem, and it would be affecting the function of the right side of the body. And my dog is calling. So in this situation, the muscles of the right side of the body are affected, and so right-sided stroke. In this situation, he's illustrating a weakness in his hip flexor muscles. So he's demonstrating what happens if you cannot flex your hip properly. Notice how his toes are down pointing. So as part of that, moving the toes in the opposite direction, or the foot, it's called dorsiflexion, would be impaired. So when you can't flex your hip properly and you can't pull up the front of your foot, then you have to get around that somehow. And that's what he demonstrates here. So notice the left leg works fine. See how he flexes his left hip on the far side forward? And then he stands on that leg and he swings his right leg around. He can't flex at the hip, so he swings the leg around, and he can't lift up his toes. So he's going to make the leg shorter by leaning over on his left-hand side and just pulling the leg through. This is called, that movement, a circling movement, is called circumduction, and that's called a circumduction gait. As you can well imagine, it's a little bit inefficient for getting around. So that's hemiparesis, or weakness on one side of the body. And it's expressing itself as altered posture of his body, as well as altered movement. In this case, it's his gait that's aberrated. Now, spasticity is very common in stroke. Not everyone has spasticity, or they might have very little, or they might have a lot, or a strong expression of it. So this is a velocity-dependent increase in muscle tone and muscle tone response to passive movement. So that sounds very complicated, but basically, if you stretch a muscle quickly, then if you've got an intact spinal cord and your nervous system is working properly in terms of messages from above, then you'll have this reflexive response of stopping the movement, but it'll be dampened. And if you've got spasticity, for example, in this image, he's got his right arm is in this position. So you could probably help him straighten his arm out. But if you moved it quickly, then the bicep muscle would spasm and would prevent you from straightening the arm. So that's spasticity. And in this situation, notice how his foot's pointing downward. Even if he manages to put the ball of his foot on the ground, if he drops his heel onto it, that'll stretch the calf muscle, and that could cause clonus, which is that shaking that I just showed you with my elbow. So as a result of the weakness in certain muscles on one side of the body, as well as tone on the opposing muscles, that could be normal tone, normal levels of tension, or excessive tension, or this spasticity, then your body posture gets pulled out of shape. And he's demonstrating that with his arm there. So the right arm is called adduction at the side of the body. His elbow's flexed, his forearm is internally rotated, and his fingers are more closed. So you're gonna have these postural alterations to a varying degree, depending upon the stroke and how the person's recovery is going. And this is going to result in poor balance and poor coordination. It's not just the muscles of the extremities that could be affected. It could be the muscles of the trunk and so on as well. So, when you have poor truncal control and poor control of the extremities, your balance is going to be thrown off, your coordination. Other effects that are common are effects in cognition, or ability to think, be able to think clearly, sometimes to inhibit, automatic reflexes. Aphasia is the inability to process language properly. So you might not be able to understand what people are saying, and/or you might not be able to form your own words. And then you've got dysarthria, which is a motor control problem with the muscles and the speech control. So if I was talking like this, I might not have aphasia. I might understand language perfectly, but the muscles that are controlling the voice are affected in somewhat similar manner in that example to the muscles that this neurologist is demonstrating that are asymmetrical in their tone, and the control of them is poor. Another issue that can happen is something called hemispatial neglect, which doesn't mean that you're not caring about yourself. It's that on one half of your body, you're much less aware of your body as well as the environment. So your internal representation of your body doesn't include, it's usually the left-hand side, doesn't include the left-hand side of your body. So you don't, if I looked at myself here, I would just see the right side of me. And if somebody called me from over here, no problem, I'd see them and hear them. If they called me from over here, even if they're right here, I'd be looking and I would turn all the way around to find them. So hemispatial neglect happens more commonly in the left-hand side. And that would be something good to know if your client has that, because there's gonna be safety issues as well as communication issues if you're standing in the wrong place and so on. 40% of people with stroke have difficulty washing, grooming, brushing their teeth and so on after 6 months after the stroke itself. Many people with stroke can't work fully or have, they have to change their work entirely. They can't work at all. Your role in the family can shift and your participation in social activities. So people's lives can get very, very narrow. And at least 30% of stroke survivors experience depression as well. Now, a couple other key things with stroke is it's common to have excessive fatigue. So between roughly a third to almost 92% of people with stroke experience an incredible level of fatigue. They might not have it at a certain time if they've just rested, but they will fatigue extremely quickly. Part of this is because there's all this weakness in the body and it takes a lot more energy to move the body. Your posture is off and your gait and so on, so it takes a lot more energy to move. If the breathing muscles are affected, you can't breathe fully, you're not getting enough oxygen. And because of the inefficiency of how your nervous system is working, instead of having a direct line, more or less direct line from the motor cortex in your brain, boom, down to the spinal cord to tell a muscle what to do. And now you have to take a very circuitous route. So it takes a lot more neural activity to get there. It takes more concentration and focus and so on. So I call that the neural burn rate. I don't know what other people call that. And because of all these problems with ambulating and diminished social role and so on, people can become very sedentary. Maybe they have depression too as well. So fatigue can contribute to sedentariness, reduce cardiorespiratory fitness, muscle fitness, and contribute to depression. And it can also be a result of these things. So it's really, a cat's cradle there of comorbid and co-contributing factors. That's my dog dreaming, just ignore that. The barking and kind of sobbing. The other thing common in people with stroke is deconditioning. So the physical activity levels of people who live in the community, so not in some kind of care facility, basically, stroke survivors have less physical activity than any of the chronic conditions of the musculoskeletal or cardiovascular system. So these folks generally are not moving much at all, which is going to make you more fatigued. So you're fatigued, and that keeps you from moving, you get more deconditioned, and so on. Then to move into that a little bit more fully, so we talked about how it's inefficient, to move when you have a stroke. So the energy costs of movements are higher. Basically, you're burning up about twice as much oxygen to walk per mile than someone who's got a normal neuromuscular system. So you're burning twice as much oxygen, and yet the cardiorespiratory fitness is usually half that of people who are the same age. So you're burning twice as much oxygen, and you're only half as good cardiorespiratory wise. So that's how you're burning a lot of energy and you're fatiguing. Now, all those muscles that have weakened, if you don't To the extent that they don't train up again, then they waste. There's hypertrophy when a muscle builds, and atrophy or wasting is the opposite. It's the absorption of muscle, basically, and conversion into fat. Muscle fibers that are still there often change their phenotype. And instead of the slow twitch muscle fibers, which are very insulin sensitive and so on, they turn into more fast twitch fibers. And these fast twitch fibers are more insulin resistant and fatigable. So this contributes to abnormal blood sugar levels and poor blood sugar regulation. So we've got a perfect storm there, right? Of the physical factors, the neurological factors, the social factors, deconditioning, fatigue, and then there's the possibility of another stroke. And in fact, within 5 years after a stroke, 40%, so 4 in 10 or 2 in 5 men will have another stroke. And the second one is worse. It'll kill you, or it's going to absorb more of your ability to function and make you more disabled. Women is only about half of that. So, 1 in 4 women will have another stroke within 5 years. So that's something to think about in terms of the exercise prescription. We'd really like to help people live a full life and live a long life. And then myocardial infarction or heart attacks, that's 5%. So within 1 year after a stroke, 1 in 20 people will have a heart attack. And then it's 3% of the cohort every year after that. So we got to keep an eye on that in terms of the exercise prescription for people. This is a chart from Haddam et al. From 2016. They're looking at recovery of upper limb function after a stroke, but they have a nice image here. And what you've got here is you've got the ability or the amount, some kind of measure of the functional ability of somebody, which would be, somewhere along here. That's zero functional ability. And this is time along this axis since the stroke at the dotted line. So people are functioning very well, whatever that is, and then they have their stroke and boom, it's quite an acute trauma and your ability to function drops like markedly, right? And at that point, it's really a medical issue and you need medical help. However, over the next, after 2 or 3 days, then things start coming around a bit. And most people, if it doesn't kill you, you will recover to a certain extent. And, certainly within the first few weeks, the first few months, at 3 months, historically, you'd say that 3 to 6 months, that's about as much recovery as you're going to get. And that perspective has changed a lot because we get a lot of stubborn people who are creative, doing things and getting better and better and better. But this maps out the different types of interventions. And in this presentations today, we're not looking at, exercise prescription by us for people who've had strokes in the first few days, weeks, probably not even until, 3 months or so. In that window, you're going to have the physiotherapists and occupational therapists working extensively, hopefully, with the person to regain as much function as they can. So the brain is in shock and some parts of it are dead, some parts of it are kind of shut down. And if you challenge them with exercise and then rest, then you will recover quite a bit of function. But you can see as time goes by, what you're going to be looking at is more and more finding ways to move your body and compensate. And then in the long term, it's your physical fitness and working on being able to live fully, doing all your ADLs or as much as you can, and interact socially. And then over the months and years, it's the maintenance of your physical condition and optimizing that are key. I add these words from Norman Deutsch. I used to think that the brain was, once you were, fully developed as a, teen or 20 something, that it never changed. But now we see that neuroplasticity, the brain and the cord, can change depending upon the challenges you put to it. So the brain and the cord change its structure and functioning in response to your activity and your mental experience. So that's very exciting. Now, like I said, we're going to be seeing people after they're medically stabilized. So the minimum for us is that the client is medically stable, and we should check in with the rehab team, which is like in Canada, it's going to be a physiotherapist and or occupational therapist, maybe a full team, I don't know. But certainly somebody who is more an acute care management person. And you want to find out if there's any corrective actions. So we'll get into some of those as we go further along. And are there any precautions or complications? For example, it'd be good to know if the person's got hemispatial neglect and is not going to see or hear you on that side of their body, and they're not going to be aware of that side of their body, for example. Now, in Billinger's paper from 2014, they map out a lovely FIT VP for stroke survivors that encompasses the early stage of things in hospital. We're not going into that. And then the outpatient and rehabilitation end for aerobic, muscular strength, endurance, flexibility, and neuromuscular. We're going to break that down, but this is a lovely summary, and I'm including pretty much all of the information on this chart over the next, 8 or 10 slides. So Billinger quotes another author in the 2014 paper where they summarize the goals of stroke rehabilitation. And I think this is nice to see, how we fit in. So basically, we want to reduce or reverse the impacts of the stroke. We can do that through aerobic exercise training, strength training, neuromuscular training, and flexibility. We can do a lot of that with most people or with many people. We want to prevent, recognize, and manage secondary medical conditions. A lot of people with strokes have got hypertension, and that's why they stroked out. They can have heart disease and so on. So there needs to be a scan for other medical or comorbid conditions. And a lot of our FIT VP is going to help address those as well. We want to maximize independence. So people being able to do their activities of their daily living. And the lovely thing about exercise is that supports people psychologically, socially, and in their role in the family and so on. We want to encourage and help people resume their prior life role, if at all possible, and or integrate into the community in a new way that's functional, that's satisfying for them and gives them a sense of meaning and purpose. We want to help enhance people's quality of life. So the pills we suggest are the poly pill of exercise. There's 4 pills there: aerobic, resistance, flexibility, and neuromuscular exercise training. And let's look at them one after the other. So for aerobic exercise training, our goals or objectives from Billinger's paper is to increase the walking speed and the efficiency. So people with strokes, it's a big deal for them to walk, and it can be exhausting, and they don't get anywhere fast, potentially. So we want to increase the efficiency of people's movement and the speed that they can move. We want to improve their exercise tolerance so they can walk faster, further, as well as move their body, doing anything. Want to help people increase their independence and the ease with which they fulfill activities of daily living. And we want to keep them from having another stroke. So we want to help them improve their cardiovascular fitness, muscular fitness. A lot of people with strokes, they have about 5 to 10 times more likelihood of falling and breaking a long bone in the year after the stroke. So muscular fitness, cardiovascular fitness, cognition are all important. And those are optimized, or they're assisted by aerobic training. And this is all going to lessen the likelihood or make it less intense or difficult. So if they have another stroke, it's less likely they'll have another stroke. And if they do, it's going to be less final than it would be. We're trying to lessen cardiovascular disease, prevent heart attacks, and we're also trying to help the person have less fatigue, and we do get the psychological bonus of less depression with aerobic fitness with stroke survivors. So the aerobic fitness is a key part of things. At least 3 days a week, up to 5 is the suggestion in both the Get P11 and Billinger's paper. The intensity is tough because it's very hard to know what someone's maximal heart rate is or ought to be if they have a stroke, because people with strokes tend to not be able to achieve their age predicted maximal heart rate. So it's often really rating of perceived exertion, the Borg scale, somewhere between 11 to 14 on the 6 to 20 scale is usually about right. Otherwise, you're coordinating that with whatever their heart rate happens to be, and you're going to ignore the age-matched controls, and you're going to use that heart rate as a measure of intensity for them. Okay. Ideally, you'd like to have 20-minute sessions at a minimum, and build to 60 minutes long. However, with post-stroke fatigue, sometimes the person may only be able to exercise for 10 minutes at a stretch. No problem. Go for 10 minutes. Go down for a nap. When you get up, move it again. I had a stroke 5 years ago, and I had very much that experience. I could exercise vigorously. No, not vigorously in our way, but I could exercise for 10, 15 minutes, and I'd sleep for 3 or 4 hours. And then I'd exercise again, 15, 20 minutes, and then I'd sleep for 3 or 4 hours. So yeah, ideally you want to accumulate 20 to 60 minutes per day, but you might have to do it in small amounts. You want to use large muscle activities. So walking is great if you can walk. If your gait is all that circumduction thing, then you might have to have a harness that unloads you, so that even though you're very weak at flexing your hip and lifting the toes, when you unload the body, that might be enough. Or you need to move to a pool, perhaps. Graded walking is when you can't walk any faster, but you increase the angle or the grade. Sometimes that's a safe way to increase intensity for people with stroke. Stationary bikes and cycles, they're great. You won't fall off that. Yeah, any kind of functional seated activity. Now, if you do the math on this, if you get up to 60 minutes a day for 3 days a week, you're looking at 180 minutes minimum to 300 minutes a week. Nobody's talking about the volume explicitly in either of the two references, but that's the kind of range you're going to be looking at. The progressions need to be slow. And again, you can increase intensity, time, frequency is tolerated, and notes. We talked about the heart rate maximum, not going to be a great guide. Again, safety and stability are vital. Can that person do this exercise without falling over, right? 5 to 10 times, it's 5 to 10 times more likely somebody with a stroke is going to fall and break a bone in their first year after the stroke. So the stability of the person, their safety is key. They may seem safe and stable, but after 10 minutes, as neural fatigue happens, then their balance deteriorates, their concentration, and so on. So they need to be monitored, they need to be supported, and you need to be alert when you're doing that. And then whatever posture you're in when you're doing an exercise, stabilizes or confirms that posture. So the emphasis would be upon before doing or at the commencement of the aerobic exercise training, whatever it is, you need to help the person get into an alignment that is toward the ideal as best they can. It should be done with a mirror, or something like that, so they can see themselves, because you're going to be ingraining this movement pattern as they are relearning how to use their body more and more. Okay, I could go on forever, and I'd love to. We're moving on to resistance exercise training. So we want to improve strength, endurance, and power. Obviously, this will probably be asymmetrical exercise. So you're going to be focusing a lot more on the hemiparetic, or the weaker parts of the body. And you need to have strength to stand, to move, to stretch your arm out, to grasp things, and so on. All this to increase your ability to perform occupational activities as well as leisure time and your ADLs. And the other thing that happens as you get stronger, then when you're lifting or carrying things, you're going to have less of a maximum voluntary contraction. You're going to have easier time. As I get stronger, I have a much easier time dealing with elements of my stroke, for example. As your muscular system hypertrophies and the physiology shifts, perhaps a bit more toward the faster twitch fibers, you'll have improved blood sugar regulation, and you're working to prevent falls. We had a whole thing around falls and how power training will be key for that. Now, we also want to do the resistance training to increase or stabilize mineral density. Mineral density often falls in people's bones with stroke on the affected side. So it's weak and it's brittle. So we want to load those up. It hasn't been proven that you can improve bone mineral density. Doesn't mean it can't be done. Nobody's just proven it yet. And cognition is improved. So resistance exercise training with aerobic exercise training has reduced mild cognitive impairment, that's what that is, MCI, by 44% in the cohort in the study that Billinger quotes. So aerobic exercise training and resistance together can really help cognition and, hopefully slow down or delay onset of dementia-related symptoms in people with stroke. In terms of the FIT VP, you want to do the resistance training at least twice, if not 3 times a week. The intensity, anywhere between 50 and 70% of your 1 rep max, according to the GET P11 and Billinger and Peers suggest that you can go up to 80%. You're looking at 1 to 3 sets of 8 to 10 repetitions, or 8 to 15 repetitions for Billinger. You're going to be doing resistance training of your extremities and of your trunk. It's not just, the trunk is your central axis, and that's really on a whack with a stroke, and it may be directly affected by the stroke. So free weights, partial weight bearing, full weight bearing activities, elastic bands, spring coils, pulleys, circuit training, functional mobility, and some emphasis on power training to bring that arm out or abduct your hips so you can step out and so on. The volume, I think I made an error there. I think 180 to 300 minutes per week is left over from the aerobic one. So just ignore that. Progression patterns are similar to regular adults. And again, the emphasis on safety and stability. So if you're working with something, you're trying your best to hold on to that weight, but you've got poor motor control, you might drop it on the foot that's also weak, and the bones are brittle, and so on. So safety and stability, you want to, when you concentrate on the form of an exercise, it's putting your body in space. It's also putting the object, if you're pushing an object or doing whatever, you're putting it in a certain place in space. So it's really a neuromuscular exercise as well as a resistance exercise for many of these things. You want to make sure movements are symmetrical and your core is aligned when doing these. Flexibility is key. So somebody with stroke, you remember that neurologist who's all curled up with his upper extremity, the lower extremity was stuck and the hip is extended and the knees locked out and so on. So through stretching, we want to drop the tone or the level of resting tension in the muscles that are normally innervated, that have not been affected by the stroke, as well as perhaps the muscles that, which might be the same, depending, the muscles that have got spasticity. So you want to help the person move toward more symmetry and better posture of the body wholly, as well as the parts of the body. When I have DA here, I haven't read someone saying that. That's my assertion. Billinger's like, yes, increased range of motion of the stroke involving the segments of the body. So that's code, right? Because your arm is stuck like this. So you want to be able to bring your arm out. And the effect of bringing the arm out instead of having it in like that is you're going to have more symmetry, better posture and movement and so on. So that's what's going on here in the second point. You want to reduce muscle tension and spasticity. So in that example, the gentleman was holding his hand like this. He would not be able to open his fingers perhaps at first. So you'd want to stretch the hand and get it more flexible and pliant. So then it would take less strength in these weak muscles to be able to open the hand, for example. So stretching is to reduce resting muscle tension and spasticity. If you don't stretch and you leave it there for a few weeks or a month or two, then it will not stretch. That's a contracture. You actually lose sarcomeres in the muscle. The muscle structurally becomes shorter. So the way you avoid that is by opening things up and taking them through range. If you're more flexible, then let's say if I can't put my arm out in front of me and I fall over, then I can't stop myself with this hand. So I have the flexibility to be able to move the hand. If I have the strength to move the hand, then I'm going to decrease my risk of falling, for example. And it's going to be easier to do things around the house, pour a cup of coffee, wash my face, shave, and so on. So the guidelines in both the fit, what do you call it? The ACSM guide and Billinger is 2 to 3 days a week for flexibility. And it could be before or after aerobic or resistance exercise training. That's both of those guidelines. I take a different point, but we'll get there. The intensity, as usual, gentle but firm and non-painful. Both Billinger and the ACSM guide talk about 10 to 30 seconds per stretch, totaling 60 seconds per muscle group. It's slow static stretching. You want to include the trunk and all the extremities. And this is a volume of, you want to make sure every muscle group gets 60 seconds 2 or 3 times a week. And this can be from static stretching, where you use another part of your body, to PNF, where you contract other muscles to try to open it up, which takes more sophistication and takes more control. Now, things get complicated. This is why you're going to have to consult with the person's OT or PT. So, if your hand's like this, you don't need to stretch your forearm this way. You need to stretch your forearm and fingers this way. If your arm is at the side like this, you don't need to stretch it across, but you want to stretch it this way. If it doesn't go up, then you want to stretch it up. You don't have to, you don't have to stretch it behind you and so on. So there's going to be asymmetrical patterns of stretching. And generally speaking, they're a heck of a lot longer than your 30 seconds. You might have 2 or 3 minutes of static stretching, and you might be doing this 20 or 30 times a day. Yeah. Otherwise, the darn thing is not going to lengthen, and you're going to be stuck in these postures. So that's all dependent upon how severe the person's stroke was, what was affected, and where along the time course of recovery they are. So that's where you need input from other professionals. Yeah. Okay, so neuromuscular exercise training. Key, again, the Get P11 is like and Billinger 2 to 3 times days a week. Yeah, light to moderate. And then they don't talk about the time. So I'm putting a DA in there. So it could be very brief, because let's say if you're trying to open your hand, it may exhaust you. It may exhaust you trying to, extend your fingers one at a time, for example. After 2 minutes, you might just be wrecked and need to rest. As you get better, you can do it longer. So maybe you can do it for 10 minutes. The types of neuromuscular training: balance and coordination, again, for fall prevention, as well as for postural control, for ability to work with your environment and so on. Tai Chi yoga, great. You've also got things like paddles, or throwing a ball back and forth, working in a pool with paddles and so on. Anything with hand-eye coordination is fabulous. And there's all sorts of video and computer games where you have this sword or something and you're like, doing some kind of Japanese sword play in a video game. Volume. They don't talk about volume. Volume needs to be high. It took you, about a year or two, at least a year anyways, to learn how to stand and walk. Well, and you were working on it all the time. You were moving your body 24/7. If you weren't asleep or if you weren't nursing, then you were exploring your body. So for neuromuscular exercise training, it's a lot of volume usually. That's my take on it. The Fit VPs that are published do not mention this. Progression is as tolerated to more complex movements. For fall prevention, you want to have unstable surfaces eventually. And you also want to have unstable loading. So if you're holding something and let's say I've got like a drum or something and it's half filled with water. So as I carry it, the water sloshes around and that's going to have unpredictable effects on my body and I'm going to have to deal with that. Safety first, but that's the kind of progression. And pretty much every day is a neuromuscular training day if you have a stroke, because unless you just cave in and you just do whatever your body will do and accept it, then you're going to be fighting for function every day of your life for the rest of your life. So I'd also say from my own personal experience, people say, oh, you can't tell I had a stroke. Well, I can on the inside. I worked really hard and I fought for it with, tenacity and a lot of support. But I'd say my whole left side is, it's obviously weaker than the right. It's so much harder for my left side to learn how to do a movement, and it forgets. It forgets fast. I learned something with my right side, it's there. It's there forever. My left side, I have to really concentrate and work at it. And if I don't train it for 2 or 3 days, then that function will fall away. So that is my exercise prescription. And I'm sure it's gone way too long, but that's this track. Thanks.